Hi, uh, I'm Joe. On the board of the Waldenstrom Macroglobulinemia Foundation. I'm part of the Vancouver support group. Uh, Huge changes in Waldenstrom's today. I was diagnosed 2002, and my choices were fludarabine or cyclophosphamide pills. I was not eligible in BC for rituximab. And my hematologist, wonderful soul that he has, sent me to Steve Treon for 3 clinical trials over 5 years. I look at what is available today, and it's a world of difference. I'd like to jump right to our questions and introduce our panel, starting with Dr. Prashant Kapoor.
Hi, I'm Prashant Kapoor from Mayo Clinic, Rochester. I am a consultant here and an associate professor of medicine and oncology, and I belong to the myeloma, Waldenstrom, and amyloidosis group here at Mayo Clinic, Rochester. Thank you for this invitation.
I should point out, for those of you who don't know, the Mayo Clinic is just one of the world's major centers in Waldenstrom's. And really, the push to develop Waldenstrom research starts with Robert Kyle at the Mayo decades ago. So it's a great honor to have you here, sir.
Thank you.
Up next is Dr. Berenstein. I'm going to have trouble not saying Neil. Dr. Berenstein has been a huge friend to the Waldenstrom Macroglobulinemia Foundation. I'm just going to say WMFC. He has provided several Zoom meetings with us. He was our medical supervisor as we produced 4 videos on for newly diagnosed Waldenstrom patients. If you haven't seen these, I suggest you look them up. And I'm just going to go with what was Dr. Berenstein was introduced before. And finally, Dr. Guy Sherwood. Dr. Sherwood, would you like to introduce yourself, please?
Oh, yes. Well, for one thing, I'd like to say hello to everybody out there. A lot of feedback. I'm a soon-to-be 23-year cancer survivor. Lymphoma, Waldenstrom's, diagnosed at age 40. And I was an active physician at that time. I'm really having a lot of issues with feedback. I'll try to take these off. Can you hear me better? Can you not hear what I'm saying? Hello? Okay, we're having some technical problems. I have been treated for Waldenstrom's multiple times, kind of like you, Joe. Fludarabine is in my background. So is buckets of rituximab and autologous stem cell transplant. And I finally completed this most recent battle with 6 months of bendamustine and 2 years of rituximab. That was over 2 years ago, and it really led to my retirement from clinical practice. But I'm happy to be here. Could I ask, does anybody else hear this echo, or it's just me?
Okay, let's move on then. We have many questions today, and we've done a bit of triaging. Consequently, we're going to try to avoid questions to you that could normally be answered well by a GP or a local hematologist. We have world-class doctors on our panel, and I want us to take advantage of that. I will occasionally direct a question to one of you specifically, but this is an open forum. Please feel free to disagree with each other, especially on topics like which is a better opening treatment, bendamustine rituximab or a BTK inhibitor. Before going on to, we're going to look at new drugs specifically, but before doing that, one of the more common questions is, What are some strategies, tips a patient can use to make the best use of their time with their doctor? What are your thoughts on that question, please? Dr. Kapoor, why don't you lead off?
Sure. So this is actually a very important question. Um, Obviously, it depends on the stage of your disease, but some of the things that are very important for the patients to discuss with the doctor are their symptoms, specifically as they relate to Waldenstrom. They are what we call the red flag features or symptoms. And also the laboratory parameters, in particular the hemoglobin, platelet count, as well as the IgM and monoclonal spike. Also, obviously, like I said before, it depends on the disease state. If there is coexisting amyloidosis, which is seen in about 7 to 8% of patients with Waldenstrom, then there are other parameters that we look at, specifically cardiac biomarkers, troponin, proBNP, NT-proBNP, or BNP, as well as 24-hour urine protein electrophoresis. So these are some of the things that we specifically inquire about in terms of symptoms, the B symptoms, so-called B symptoms associated with weight loss, loss of appetite, drenching night sweats, and fatigue, as well as other symptoms such as bleeding, whether it's nosebleeds or other areas that are bleeding, including skin hemorrhages or ecchymosis, as we call them, and also blurring of vision and other visual disturbances.
Anyone
So
else care to comment?
I'll add a more practical side to that. And I find that it's valuable for a patient to come to the clinic with some support, meaning either a spouse or a child who can make sure that the important questions are asked and take notes or remember exactly what the answer is. Sometimes we'll have a long discussion, and I find that the patient, under the stress of the situation, doesn't sort of remember a lot of the things that we talked about. So it's good to have a support person with you. I appreciate that, and I also think it's good to come in, as Dr. Kapoor said, if you're having symptoms or problems, make sure you think those through before you come, and put them on your piece of paper, and make sure you tell us about them so you don't forget. So I find those things are making a more efficient meeting when a patient comes to clinic.
Thank you. Dr. Sherwood, you've been on both sides of the desk. Thoughts?
Yes. Well, I think the most important thing for a Waldenstrom patient is to, once they've received a clear diagnosis, is to educate themselves as best as possible. I think once you try to read as much about this disease as you can, and of course attend conferences or participate in these sort of events, I think this makes things much easier for some people to understand the illness, and also helps you deal with the subsequent difficulties one may encounter during your journey with Waldenstrom's. So I'm a big believer in education.
Thank you. A question for Dr. Berenstein. Your BROM trial has been very successful in both the rate and depth of WM remissions, but with bendamustine rituximab going out progression-free survival of 6 years, it'll be some time before we know if the depth of remission translates to progression-free survival. How soon do you think it will be before you see evidence from the appropriate Kaplan-Meier graphs that depth of remission will matter in this trial?
Well, you've brought up a very good point, and that's part of the reason why we have these surrogate endpoints. And we have several surrogate endpoints in this trial. Those being the primary endpoint, which is a surrogate endpoint, is response, and CR and VGPR. And These have been associated in other trials with improved progression-free survival. I won't say overall survival in this disease, but certainly progression-free survival. So those patients who get a CR and VGPR, we call those major responses, actually have a better progression-free survival than patients in other trials who only have a partial response. So we feel that it would be impractical to keep this trial going for 10 years. So that's why we have these surrogate endpoints. And the other surrogate endpoint that we have, which we are starting to report on, we're starting to get data back from, is MRD. So that has not really been done in a lot of patients with Waldenstrom's. We are doing MRD from the bone marrow and the peripheral blood. We are seeing the peripheral blood clear in the majority of patients. And we're seeing improvement in the bone marrow. I mean, every patient's having improvements with MRD, but not all of them are becoming MRD negative in the bone marrow. But some of the patients are. And, that, again, would be in many diseases. If you look at myeloma, decisions are now starting to be made on depth of response, which includes basically CR and MRD. So that's the answer, is that we're trying to rely on these so-called surrogate endpoints because it's impractical to get the type of PFS that really, I mean, eventually we'll get it, but it can't keep the trial going that long.
Okay, this is an open question. Waldenstrom patients are used to getting drugs rather late. CLL jumped to BTKs long before Waldenstrom patients in Canada. What about bispecifics like epcoritamab? For those of you watching, this is a highly effective drug in aggressive lymphomas. It's very high tech. It targets CD20 on the cancer cell and links to CD3 cells and brings them in to finish off the cancer cell. It's now in trial for CLL. Gentlemen, is there a future for bispecifics in Waldenstrom's? And if so, could one of you please explain the mechanism of action?
Sure, I can take that. It is true that many of these drugs that we are currently using in Waldenstrom are borrowed from other malignancies, including other non-Hodgkin lymphomas as well as multiple myeloma. Having said that, when it came to BTK inhibitors in a head-to-head comparison, the first head-to-head comparison was actually in Waldenstrom in the ASPEN study that Dr. Berenstein discussed a while ago. And this actually brought forward a lot of knowledge about the comparison between these two BTK inhibitors, ibrutinib and zanubrutinib. And even though the mechanism of action is similar, as well as the efficacy is somewhat similar in certain populations, there was a huge difference in the quality of life as well as the side effect profile in terms of the number of patients that were affected by different adverse effects, and they were largely favorable, more favorable for zanubrutinib compared to ibrutinib. Now, specifically as it relates to bispecifics, epcoritamab, as well as some of the other bispecifics targeting CD20, as well as some other markers, there are studies that are about to start with epcoritamab in the US, and there are studies with epcoritamab that are being planned and are about to start in Europe as well. There are other bispecifics as well that are going to be used soon in other clinical trials in the US, I can say for sure, specifically for the WM population. And as we speak, there are some trials that are already ongoing that are allowing patients with different non-Hodgkin lymphomas, indolent lymphomas, that are also enrolling Waldenstrom patients.
Dr. Berenstein, any thoughts on this?
Yeah, I mean, these are exciting new reagents. They're making a big impact in lymphoma. They're making a big impact in myeloma as well. And initially, they've been used as for patients with recurrent and refractory disease. I actually had a patient with a low-grade non-Hodgkin's lymphoma on an epicoritamab clinical trial, who had a complete response to the epicoritamab, but did have toxicities. They're not without toxicities, and so I think we have to appreciate that these will, and I think that the excitement is the possibility of bringing these earlier on in the disease course and combining them with other treatments, whether it be chemotherapy or other targeted therapies. These will have a role. These should come to Waldenstrom's patients. If we're using them in other low-grade lymphomas, just like we use bendamustine or Rituxan, that was really developed in follicular lymphoma initially, we should be using these, and we should be testing these. We should probably be using these eventually in Waldenstrom's. The sooner the better. And the problem is that Waldenstrom's is such a small subset of the patients, and it's hard to do a randomized trials in patients with Waldenstrom's of some of these new reagents, but they will work, and they'll be exciting, and they'll make an impact, I'm sure.
I'd just like to add something that for most of these, with most of these bispecifics, they are being given continuously, and as you know, the goal is to bring the patient's own T cells, which are the soldier cells next to the cancer cells, so that the soldier cells can attack. And as Dr. Berenstein just stated, these drugs are not without side effects, and the two major side effects are cytokine release syndrome, where because of this interaction between the cancer cell and the soldier cell, the T cell, there are a lot of chemicals or inflammatory markers that are released, and these are called cytokines, as a result of which patients don't feel good. They can have fever, they can have what we call sepsis-like features, where they would just feel bad, their blood pressure could go down, they could have issues with different organ function, have problems breathing, etc. Plus, the second major side effect is what we call ICANS, or it's a neurological syndrome, immune effector related, as a result of which there can be altered sensorium, or the mental status can be affected. Having said that, there are drugs to control those side effects. And the other issue with bispecifics are that most of them have been used continuously until progression. In the field of Waldenstrom, we are actually planning trials for using these very potent agents for a specific duration of time, a year and a half at most, so that we get as much benefit as we can, and not use these agents on a continuous basis.
Thank you. Dr. Sherwood, as a patient and a doctor, anything that you would like to tell newly diagnosed patients that would help them on their journey? I remember when I was first diagnosed, I felt like I was poleaxed, and it took me a long time. There was no support group. There was no WMFC. So what would be your main advice to a newly diagnosed patient, besides look at our 4 WMFC videos, if I can put a plug in there?
I think, yes, surround yourselves with people who love you, first of all. Secondly, this may sound a little bit strange, but after some time you will have to embrace the journey itself, because it can be a long one. Mine has been 23 years. And I will come back again to the importance of education in multiple forms. Education from your physicians, from the allied health professionals, education from the volunteer groups like the Waldenstrom groups that exist all over the world, and try to maintain a positive attitude, which I know is difficult to do sometimes, many times. But basically keep your chin up. I don't think many people will die of Waldenstrom's in the near future. They may die of other issues, perhaps heart attacks or strokes or what have you. But I think Waldenstrom's will not become the one that will get you, I guess, at the end.
That's all I can basically say.
Thank you. Dr. Sherwood is an auto transplant patient. I'm an allo transplant patient, but it seems that new clinical advances have made these types of transplants less attractive. What are your thoughts on CAR T cell transplants for WM patients who are running low on treatment options? Dr. Bernstein, would you like to take first crack, please?
Yeah, I mean, CAR T cells, again, are like bispecifics in that they are sort of revolutionizing our treatment. They're providing another very important option. They've been first developed in diffuse large B-cell lymphoma. And in diffuse large B-cell lymphoma, they were shown to be very effective, even causing some possible cures in a small percentage of patients with recurrent and refractory diffuse large B-cell lymphoma. There's a plateau in the survival curve. I mean, the patients are still being followed, many without evidence of recurrence. Doesn't work for all patients, but many patients it does. And based upon that success with the initial trials in recurrent and refractory diffuse large B-cell lymphoma, it's now being moved up as an alternative to stem cell transplant in the diffuse large B-cell lymphoma, and initial results look very positive. And it may be that that at some point very soon, this will be the option for patients with recurrent diffuse large B-cell lymphoma. They will have CAR T cells rather than a stem cell transplant. And based upon all these findings, it's been applied to multiple myeloma. There are several different CAR T cells in multiple myeloma. These are also have been approved from regulatory perspectives, and are starting to be will soon be available in Canada outside of clinical trials. So it's just a matter of time till we see this again in Waldenstrom's. The trials haven't been done in this lymphoma, as you know, and we have these requirements to do the trials in most diseases. Doesn't necessarily have to be a large randomized trial, I don't think, based upon some of the other results that have been done. But that's open to discussion in this type of orphan disease or uncommon disease. But again, I'm sure it will be effective. The big debate now is are bispecifics going to be an alternative to CAR Ts? CAR Ts are difficult in many respects because there's a logistical side to it. Cells have to be taken from a patient, they have to be processed, they have to be shipped, they have to be resent back, they have to be administered. The disease has to be stable while all this is happening. It's an expensive process, it's a time-consuming process. Could off-the-shelf bispecifics replace that, be as effective? And that's some of the questions that are going to be addressed over the next several years in some of these other diseases. But there's no question that these are going to make transplant probably less valuable or less necessary in patients with Waldenstrom's. I would be interested to hear what Dr. Kapoor has to say about that.
Sure, I would frankly agree with whatever you've said, Dr. Bernstein. I'd just like to add there are specific targets against which CAR T therapies are being evaluated in Waldenstrom, specifically CD19 and CD20. And these CAR Ts have actually been evaluated in other lymphomas. With regard to the CD19, there was some preliminary data presented by Dr. Leah Palumba from the Memorial Sloan Kettering Hospital. It involved 3 patients. Unfortunately, the responses ranged from 3 to 26 months, so a little over 2 years. And only out of those 3 patients, one, I believe, achieved a complete response. In one case, it was partial response, and in the third patient, there was only evidence of stability of disease. But the CD20 targeted CAR T therapy is being evaluated at UW in Seattle, and that seems to be somewhat more promising. There is a trial that is going to open at several centers in the US, specifically with that CAR T MB106. The preliminary data that was presented at the IWWM workshop in Madrid indicated that two patients who had received it had shown good response, and in one patient it was maintained at 15 months after treatment, and that patient still had continued remission. In the other patient, unfortunately, there was what we call non-relapse mortality. The patient's disease was under control, but unfortunately he succumbed due to COVID-19 infection, which happens to be a major issue. Infections in general happen to be a major issue, both with CAR-T as well as bispecifics. And while CAR-T is one and done deal, at least for the moment, with bispecifics, we have to give them for a longer period of time. And the longer we give, the more likelihood of patients actually getting some of these side effects.
Okay. Dr. Sherwood will remember probably, hopefully, almost 20 years ago when two wonder drugs came out, Zeppelin and Bexar. These were conjugated radioactive isotopes. I believe it was Zeppelin that used iodine-131. The drugs fizzled out. They got approval, but were removed from the market. Now there's another one coming up, iopofosine. Do you think this has a better future than Bexar and Zeppelin? And if so, why? Who would like to lead on this one?
I'm a family doctor, not an oncologist, hematologist. I would defer to the other colleagues.
Sure.
Well, I can talk a little bit. I'll say a little bit about Bexar and Zevalin. I mean, actually, Bexar was the I-131, and Zevalin was the yttrium. Zevalin was a little easier to use. Bexar both of them had some very, very promising results. We actually did a trial here in Toronto at Sunnybrook. I was actually the PI on that, of Zevalin in patients as a consolidative treatment after with low-grade lymphomas, and it can accomplish what 2 years of maintenance rituximab can do with one single infusion. So but unfortunately, those drugs were developed around the same time as rituximab, and rituximab seemed to win the race. And rituximab is a lot safer. It's a lot easier. With Zevalin, for example, it had to be administered by nuclear medicine specialists. It was difficult to ship and store and all sorts of things. So they had some practical issues that I think prevented them, that made it more difficult for them to be marketed and of value to the pharmaceutical company. So in Europe, they used a lot more Zevalin than we use. We don't use any Zevalin now. But so I think that they were active agents, but there were a lot of practical aspects that made them difficult to commercialize.
So I'd just like to add that specifically that iopofosine, the CLR selector agent 131, is currently being evaluated in Waldenstrom in that trial CLOVER-WaM. And the primary outcome measure of that trial is major response rate, and patients only with relapse refractory Waldenstrom are allowed to participate. And it's the agent is given over 2 cycles. Some of the, while it appears to be quite promising, some of the side effects are related to what we call cytopenias or myelosuppression, because the marrow gets cleared of Waldenstrom cells, but unfortunately there is impact on normal good cells as well. And so something that we need to watch out for specifically with this kind of an approach.
Thank you. A question for you, Dr. Sherwood, as a family physician and as a patient. RSV vaccinations, are they suitable for Waldenstrom patients? Would you, right now you pretty well have to be over 65, but are they suitable for immunocompromised patients?
Well, you're asking me these difficult questions that are a little bit out of my league. I certainly am a strong supporter of vaccination, obviously. I mean, I've had all my COVID vaccines and boosters, and of course, influenza. Uh, I'm not quite sure if RSV is available to me. I'm not 65 yet, as you can tell. And, but should it prove to be of any benefit in preventing an infection with RSV, I would certainly consider it. And I'm not sure what the Oncologists Association in Canada, what their feelings are about RSV vaccination for immunocompromised patients like myself.
I'll make a few comments, and I mean, in general, I mean, I think patients with B cell malignancies may be at risk for more severe viral illnesses. I mean, COVID, for example, flu, for example, RSV, for example. So vaccines can be important to attenuate that, to reduce severe infections, to reduce even any infections. But the big problem is that people with B cell malignancies have a reduced ability to mount really good immune responses. Now, when you're in remission, that's not quite as big a problem. But if you're on certain treatments, for example, if you're on rituximab, you will not mount any. I mean, 1 in 10 people on rituximab will mount an immune response to COVID vaccines or flu vaccines or any vaccines, RSV vaccines. And if you're on BTK inhibitors, it's the same story. 1 in 10 patients will mount immune responses. With rituximab, you should be off rituximab for 6 months because it destroys B cells, and B cells have to reform or redifferentiate from stem cells. That process takes about 6 months at least. Some people say 12 months, but I think 6 months is a conservative period of time. With BTK inhibitors, you don't have to wait as long because it's not like the whole lineage is being eliminated. It's more functional, and the B cells will reconstitute more quickly. But so I don't think that these vaccines will hurt. I think they are of value if you can get a good immune response. I don't think that vaccination will hurt you if you're on these treatments. You just won't get an immune response. You may falsely think that you're protected when you're not protected. And if you're not in these treatments, then I definitely think that they're of value to you. What's the practice at the Mayo Clinic?
So at the Mayo Clinic, we give vaccine. It's to RSV vaccine specifically, since the question was related to that. So we give irrespective of the age. So if Dr. Sherwood were a patient at Mayo, we would be giving you the RSV vaccine today. Now, it's very important to understand that the ability to mount response is severely compromised in patients who are on active therapy, particularly in patients who are on active therapy. And also the large trials that led to essentially the FDA approval of these vaccines excluded patients who were immunocompromised. So some of this is actually extrapolation of that data. And so you will be receiving if you were a patient of mine.
To follow up on that, what about patients who have not had? Oh, sorry. Go ahead, Dr.
Go ahead.
Bernstein.
Sorry, interrupting.
No, go ahead, please.
Well, I was just going to say, I mean, at least in the field of COVID, that brought up another option, which was what we call pre-exposure prophylaxis with monoclonal antibodies. So for a period of time, we had something called Evusheld, which was a monoclonal antibody, which would give you 6 months of prophylaxis against and protection against the older variants, COVID-19 variants. Now there is a new monoclonal antibody called Supernova that is in development, that there will be a readout very shortly, and that might be a value against some of the newer Omicron variants that are circulating, at least in our province and probably around North America as well. It would be nice if we had something like that for RSV. I'm not aware that there is an antibody that can provide this type of protection for RSV.
I,
for immunosuppressed patients.
I do recall receiving a fair amount of IVIG when I was in the United States. And then when I came to Canada, I was given subcutaneous IG, which I'm not quite sure how beneficial it was to me. Maybe it was a very subtle effect. I did not end up in the hospital with some difficult infection, but I don't think it really reduced the amount of infections that I regrettably obtained from my patients, mostly those snotty-nosed kids. But I think anything you can do to prevent infection is a good idea. The risk of infection to me, given my career, is what essentially retired me from clinical practice. The year before I retired and I was heading towards treatment, I was virtually sick almost all the time, despite being on IVIG, or I'm sorry, subcutaneous IG. And my particular hematologist oncologist said that that was it for me in terms of practicing clinical medicine, and subsequently started me on bendamustine and rituximab. I have not returned to clinical practice because of the risk. I feel that sick patients, of course, they're sick, they come to the doctor because of the risk they pose to me. However, I do bend the rules a bit. I still go venture to the medical school and teach the first and second year students, just to try to keep at least a foot in the game, if you will, or a hand in the game. But I certainly wish we had a way to greatly reduce our risk. By our, I mean immunocompromised Waldenström patients to get treated. I mean, that was more effective than the treatments I received. To me, basically, isolation. I mean, within reason, isolation has been my go-to. And since I retired from clinical medicine, I've not been sick once. I'm not sure if there's any correlation, but that's what has happened for me in any event. And I've stopped taking the subcutaneous IG.
Thank you. Moving on or moving back to new drugs, what's your thoughts about drugs targeting CXCR4? I know Dr. Treon or Dr. Castillo had a trial in Boston. Any thoughts on this?
So I can say that there are two trials that I'm aware of. One was this with this agent called ulocuplimab that seemed quite promising in the sense that the study that utilized this agent only enrolled patients who had CXCR4 mutation. And when this agent was used in combination with ibrutinib, a BTK inhibitor, the activity or the efficacy of BTK inhibitor was enhanced as if the patient did not have the CXCR4 mutation. And just to back up a bit, patients who have wild type CXCR4 are able to respond much better to BTK inhibitors because CXCR4 sort of makes the Waldenstrom cells more resistant. And ulocuplimab and the other drug is actually an oral agent called mavorixafor. These agents are CXCR4, anti-CXCR4. One is a monoclonal antibody and the other one is an oral agent, a CXCR4 inhibitor. It sensitizes the cells, Waldenstrom cells, to respond to BTK inhibitors. And so the time for the patients to respond was similar in the CXCR4 mutated population in comparison to historical trials or control population of CXCR4 wild type. So in that sense, there was good activity noted, but there is no single agent activity with these agents. It's important to understand that. And unfortunately, specifically with ulocuplimab, the trial was prematurely closed not because of lack of efficacy, but because the drug company decided against continuing the drug's development specifically for Waldenstrom.
Any thoughts on
I mean, I
that,
think
Dr.
it makes,
Bernstein?
yeah, I think it makes great sense to be going after these other pathways that may be playing a role in the biology. And we know, I mean, that was part of the things I tried to show earlier in my presentation was that patients who have CXCR4 mutations behave differently. And similarly, if you have a wild type MYD88, you behave differently. And then there's these whole host of other genes that may be playing a role as well. And maybe eventually we'll get targets for them. And eventually, I hope that we'll have a more personalized approach where we identify the profile of the Waldenstroms in a particular patient and provide the combination of drugs that will target these different pathways, whether they be done together or sequentially or whatever. But the point is that I think that's the way of the future in oncology to some extent. And so I think this is an exciting next step. It's disappointing with ulocuplumab because I mean, I saw the initial, they call swimmers types plots, and they were all, I mean, almost everyone responded. I mean, it was quite striking. And in Waldenstrom's, I understand it's not as effective in some other malignancies, and that's for some reason, that's part of the reason why they decided that they're not going to invest their money in that drug, but someone should try to develop it.
If I can have you continue, Dr. Bernstein, we just had a pop-up question in the chat. We use bendamustine rituximab commonly as first-line treatment in Canada. What happens if a person gets 10-year remission? Would you retreat with bendamustine rituximab, or would you feel compelled to go to a different treatment?
Well, that's a good question. Well, success is success. If you have a really good response, in general, in oncology, we tend to repeat things. But that's not a simple question to answer because it's going to take into account a lot of other factors at the time. What's the patient's age? What's the patient's... I mean, there comes a point when you may not want to be delivering bendamustine again. Bendamustine's hard in the bone marrow. May not have the reserve. 10 years later, the patient's age is different. There are other comorbid illnesses, even though the response was very good. And you'd like to, I mean, generally when we repeat treatments, we sort of think that we're going to get at least half the duration of response as we had before. So that wouldn't be bad. But the point is we have a lot of other options now. And if the patient doesn't have a contraindication for a BTK inhibitor, again, we could expect 5, 6, 7 years from a BTK inhibitor. If the patient doesn't have, comorbid illnesses that would prevent it being given. And 10 years down the road from now, I think there's going to be a lot of further advances. So to say right now we would give the patient bendamustine rituximab when we may have other new drugs available, as we talked about, bispecifics, CXCR4 inhibitors, other drugs like that. I mean, I'm hoping that there'll be a whole new a bunch of drugs that we'll be able to use 10 years down the road. So I'd say it's unlikely the patient would get BR again. I think there probably will be better options.
What about daratumumab? Often we treat patients and there's still clonal plasma cells. The patient has a lymphoma treatment. It's hard to get a CR. Does daratumumab have a future in Waldenstrom's to knock out the clonal plasma cell population? Dr. Kapoor?
Well,
sure. So the short answer is I still think there might be a role for anti-CD38 monoclonal antibodies, be that daratumumab or cetuximab, both of which are currently approved for multiple myeloma. Because Waldenstrom is a unique malignancy and we do see persistent or residual plasma cells, specifically after certain therapies that are more lymphoma compartment-directed therapies, there might be a role. So far, daratumumab has been examined as a single agent in patients with relapsed refractory Waldenstrom, and there wasn't much of a single agent activity, as a result of which the study that we participated in as well at Mayo Clinic was again prematurely closed due to some futility based on the statistical estimates that were built in the trial. Having said that, I think if it is used in a sequential manner, it might be a good drug, because both DARA as well as isatuximab are frankly very well tolerated agents. So there is more to come. And there are currently trials that are being planned to utilize these agents in sequential manner.
Thank you. Let's switch up and go to neuropathy. Neuropathy seems to be the major complaint at these support group meetings. So it seems that research in neuropathy is almost non-existent, perhaps because of the small patient base. At your respective institutions, how do you determine if the neuropathy is WM derived, or is that even important? And how do you treat it, i.e. medications, electrical stimulation, or IVIG? Dr. Berenstein, would you like to lean on this, please?
Yeah. Well, I mean, this is a complex question. One has to have evidence of neuropathy, and one has to have evidence of Waldenstrom's to have some suspicion that the two are related. So clearly, we have to establish the diagnosis of Waldenstrom's if it's not established in a patient with neuropathy. I tend to like to see high titers of anti-myelin associated glycoprotein antibodies. That gives me, although the fact of the matter is it may not be predictive of response, but I sort of think, well, this is something that we know can bind to nerves, and it's probably coming from the IgM, and it's something that gives me a little added confidence that that they're related, that they're all related. So that's the first thing is I like to see EMG studies, electrophysiologic studies that say that yes, there is some demyelination. There are other causes of nerve injury that can be caused by other diseases, and part of the process here is ruling out other diseases that can be that can cause neuropathy, and some of them are quite common. I mean, diabetes, for example. I mean, I'd say a large percentage of our older population have some level of diabetes, and that's known to predispose to neuropathy. There are a whole bunch of other diseases, collagen vascular diseases, that can cause neuropathy, which we have to exclude. Some drugs can cause neuropathy. Previous treatments can cause neuropathy of chemotherapy treatments, for other malignancies if they've ever had that. So it's a really complex process to first of all establish that yes, we think that this neuropathy is related to the Waldenstrom's. It's good to get a neurologist involved. Often, if you get and then the treatment, as you have indicated, is quite vast, but I'd say for the most part not as satisfying as we'd like. Drugs like gabapentin, tricyclics, whatever, they help a little. They don't eliminate it. IVIG has been used. I've had some patients who've had, if they have neuropathy where it's not entirely clear that it's the Waldenstrom's related neuropathy, the neurologist sees the patient, may give them a trial of IVIG, and I've seen some patients with some improvement from IVIG. But once you've exhausted other possible causes, and you're certain that the two are, clearly are entities, then I think a trial treatment. Now, in terms of treatment principles, my treatment principle is if you really believe a patient has Waldenstrom's related neuropathy, you should give them the best treatment for Waldenstrom's. I'm not a big believer in just using rituximab. I don't think that that's an ideal treatment. Some centers do use rituximab, but I think it's like using a water pistol, rather than a real weapon or whatever. And so I think that I would give them whatever your center believes is the best treatment for the Waldenstrom's. If I'm going to, if I think that we have to try to improve the Waldenstrom's, improve the polyneuropathy by treating the Waldenstrom's. So that's my views on that.
Thank you, Dr. Sherwood. Any thoughts on this? as a
Well,
patient and a GP.
I know a lot about neuropathy as a patient who has suffered from it, but mine was mostly brought on by the use of bortezomib. I was on a clinical trial
Right.
with Dr. Trion's group, and I was unable to complete the sixth or the eighth cycle. I don't remember because of a terrible neuropathy which I did not have prior to the trial, and this was quite an experience for me in my life. Velcade-induced neuropathy was very disabling, and my colleagues in medicine will understand when I say I was on 200 milligrams of morphine a day for almost a year just to try to function. Fortunately, the neuropathy diminished over time. I no longer require any analgesics for my neuropathy, but I am also concerned about treatment-induced neuropathy, things like autonomic neuropathy, which we don't seem to measure very well. Other things such as CNS effects. You know, we all know about chemobrain. I certainly think that chemobrain is a big problem. And I think for people like me who have been treated multiple times, which is likely to be the case in any Waldenstrom patient who lives a long time, if you will, they'll require multiple treatments. We need to really focus on giving the patient the least damaging treatment possible. And further, I would like some of these studies to evaluate the long-term effects of some of our drugs. We know how well they do in 1 year, 2 years, but we don't know what sort of residual problems are left over 5, 6 years down the road. I'm in that category. I've received lots of treatment, and now I do believe I have some problems related to my treatment history. However, I am alive, and I have grandchildren, so I'm very grateful for that. But I certainly would like to see a bit more of an effort in that respect. In terms of diabetic neuropathy, well, I'm a family doctor. I know about this. It's extremely difficult to deal with, obviously, and very frustrating. And I suppose the person who comes up with a treatment, an effective treatment for diabetic neuropathy and perhaps the other ones, will win a Nobel Prize in medicine, perhaps. It would be a grand day for all of us.
Dr. Kapoor, what is the Mayo experience with this topic?
So, as was already indicated, this is a very difficult to treat condition, and there are different mechanisms. We have to obviously, at the time of the diagnosis, go into the pathophysiologic underlying mechanisms, whether it's immune mediated via the IgM autoantibody against the peripheral nerve antigens, or it is related to what we call cryoglobulinemia, again, IgM mediated, or if it's related to amyloid deposition, which can happen. And very rarely, there's this condition called peripheral neurolymphomatosis, where patients can have spinal nerve root involvement. So there are different approaches, but suffice it to say that if it is mild, we avoid treating it. But if it's moderate to severe, then definitely we discuss the risks and benefits before commencing any kind of immunosuppressive therapy. The studies with rituximab were unfortunately underpowered. And there is also this potential to induce what we call IgM flare associated worsening of neuropathy, albeit it's just what we call transient effect. There is obviously high rate of bortezomib induced, as we just heard, neuropathy. Fortunately, we have learned to use bortezomib in a better manner. We don't give intravenous or twice a week therapy anymore. It's no longer more than once a week, if at all, and it's given under the skin as opposed to subcutaneously, as opposed to intravenously. Unlike myeloma patients, Waldenstrom patients are inherently predisposed to getting high rates of neurotoxicity or treatment emergent neuropathy as a result of bortezomib use. The effect of IVIG is short-lived in my opinion, the BTK inhibitors have also shown to improve and stabilize neuropathy. There is currently a trial going on in the US utilizing rituximab in combination with acalabrutinib in patients with IgM neuropathy. Again, depending on whether it's amyloidosis related or cryoglobulinemia related, there are different treatments as well.
Thank you. I'd like to ask all three of you your opinions on clinical trials for patients. I am a fan. Dr. Sherwood is a fan. Talking a patient to patient, it is almost impossible to talk someone into investigating clinical trials because of the fear factor. Thoughts, please? Dr. Sherwood, how about you lead off?
Sure. It was not a very difficult question for me whether I would participate in a clinical trial or not. Of course, I want to participate. I thought I was going to receive the best care possible, which I did. And I thought I was going to get leading edge technology or treatments, if you will, which I believe I did. Not all my clinical trials were joyous. For example, the bortezomib one was not an easy one to do, but I felt that at least I was contributing to the advancement of science or treatment in Waldenstrom's. And I think people who do participate in clinical trials tend to be more altruistic than others. I think it's a bit of human nature. If you can dispel the fear and convince people that they will receive better care and a better chance at that, at winning the lottery, if you will, I think that will hopefully help people consider participating in clinical trials. Who knows, when I relapse or when it's time for me to get treated again, if there's a bright new shining star on the horizon, I certainly will consider using that in a clinical trial if available.
Dr. Bernstein?
Yeah, well, for me, it's sort of a no-brainer. I mean, I think that all of the treatments that we have at this point for almost all of oncology and hematology oncology are based upon clinical trials. If we didn't do clinical trials, we wouldn't be able to offer the treatments that we have now. I think that in a general, I mean, a principle is that we only do trials with treatments that we think are promising. We never try a treatment that we think is going to be harmful or worse. I mean, it's always something that we think is going to eventually improve the management of the disease. Sometimes there are toxicities that may arise and eventually, such as, let's say, with the bortezomib, and as Dr. Kapoor said, eventually solutions are found. It's unfortunate if you suffered that toxicity, but eventually solutions are found so that these toxicities are again resolved or improved, or for others. And I think that the other important thing, which I also think is important, is that you get access to new drugs, new treatments years ahead of when they will eventually become available for us in Canada, funded for us in Canada. And some of these are home runs. I mean, I think back, for example, with rituximab, when we were doing clinical trials with rituximab, people in our clinic had rituximab 2 or 3 years before the general population, and it turned out to be like a home run, more or less. I mean, it's only, every trial with rituximab has been successful, basically, almost. So there's many reasons why people should go into clinical trials, especially in rare disease like Waldenstrom's, where we need every patient to help contribute to, developing better treatments, improved treatments. So I'm a big fan of clinical trials, for sure.
Dr. Treon likes to tell the story when he was working in the myeloma section of a drug called PS341, which became Velcade and we now know as bortezomib. It was a phase 1 trial, and the patient was going into palliative care, and he didn't want to go. They kind of bullied him. He went into it and got a fabulous remission. And several months later, he went back to the doctor's office and asked for a prescription for Viagra. I mean, it doesn't get much better than that. I think the opportunities are fabulous in clinical trials. I got rituximab before I was allowed to have it in BC, rituximab and thalidomide. And you definitely get excellent care, whether your treatment is in Boston, the Mayo Clinic, Sunnybrook, or out in Vancouver here. Dr. Kapoor, any further thoughts on clinical trial before we move on?
No, I would agree with everything that's been said. I am also a firm believer in clinical trials. A lot of thought is put into while designing these trials. Obviously, the patients get access early on, and as Dr. Sherwood said, inherently they have this altruistic nature because they know they are going in without knowing whether the drug would benefit or not to them, but definitely it would inform the field, it would move the field forward. And as Dr. Berenstein stated, a lot of people benefited just by enrolling themselves in these trials. And as you said, that you got access to these medications so early on, much before the drugs actually got approved. Having said that, one has to understand that the real world outcomes may not always mirror what we see in clinical trials. I might want to participate in a clinical trial. I might want my patient to participate in a clinical trial. But the eligibility criteria may not allow the patient to participate. So there are things that we have to understand about clinical trials. They are picking the patients. They are picking patients who are otherwise healthier than the general patient population in the real world. But these clinical trials have actually allowed us to move the field forward and bring newer therapies to patients with Waldenstrom. Without these trials, without the trial first showing, let's say, beyond rituximab, the DRC, which the Greeks conducted, the Greek regimen DRC, showing benefit of utilizing this drug in utilizing this regimen upfront, and bendamustine rituximab, all these along with the Aspen trial bringing zanubrutinib, and the trial that Dr. Treon conducted with ibrutinib. These are actually landmark trials that have advanced the field, and I'm sure there are many, many more to come. Ultimately, I think we would have to start doing randomized control trials, and such trials are actually scarce in Waldenstrom macroglobulinemia. Very sparsely done, but in order to truly figure out whether one regimen works better than the other, we have to conduct. And for a rare condition, as Dr. Berenstein said, we have to join hands. This has to be a collaborative effort across the world. In fact, there was a session at the IWWM in Madrid where we have figured out, or at least laid out, I shouldn't say figured out, but laid out certain guidelines to conduct these trials. What should the appropriate control arm be like? How should we move from using BTK inhibitors on a continuous basis to the approach that Dr. Berenstein has taken in the Brahms study, where utilizing the power of BTK inhibitors, but also trying to reduce the side effects by confining or putting that treatment for a fixed or a finite duration in order to get the best of both worlds. So there's much more to come because of clinical trials.
Thank you.
And I applaud every patient that has taken that chance, the gamble, to get on the trial.
I would like to add, if I may, that even though I had a difficult time with the bortezomib trial, the phase 2 trial led by Dr. Treon, it did lead to improvements, I think, in the way the treatment was administered. We talked about lower doses. We talked about less intense treatment regimens. So I'm grateful for that, because I do have friends in the community who have benefited greatly from that medication. And I think they've avoided many of the side effects because of the results of that phase 2 trial. So I may not have benefited too much, but others have, and I'm okay with that.
And WM still remains an incurable disease, so there's much more work to be done. And what I do see with many of these clinical trials is that they allow patients to live longer, to see the next regimen or the next therapy that works. And that is how we are going to make progress incrementally in this field.
Thank you. We're running out of time, amazingly. Let's switch to cold agglutinin disease. There's a few inquiries for people who have not done well with cold agglutinin disease during and after Waldenstrom treatment. Are there any other options for them? Your thoughts on this, please. Let's start with Dr. Berenstein, please.
Well, I think one has to control the IgM levels, and I think trying to keep people in remission as best as possible is very important. Local measures, such as, I mean, I have one patient with cold agglutinin disease who says winters are rough, but she wears 3 pairs of gloves or whatever and sweaters, and she keeps warm, and she avoids the cold weather that can precipitate the hemolysis. But I think that she has been in remission after a treatment, and she's really had minimal problems with cold agglutinin disease. So I think you have to keep the disease in remission with whatever means are necessary to avoid even low levels of the paraprotein in the IgM.
I think it's important not just to treat the numbers; you have to treat the patient. And if cold agglutinin has a major impact on a patient's quality of life, I think that by itself should be an ample reason to be treated, in my estimation.
For sure.
With time running low, a very, very common question is about the appropriateness of taking zanubrutinib or ibrutinib while doing COVID vaccines. We had word from Dr. Castillo. He recommends all his patients get the COVID shot, doesn't care if it's Pfizer or Moderna, as long as it's the latest variant. If you get COVID, you test positive, you keep on your zanubrutinib, but if you have to go to Paxlovid as the antiviral, you will need to stop zanubrutinib. If you go to remdesivir, you will not. Do you gentlemen concur with that?
Yeah, I would largely concur. If given a choice between Pfizer and Moderna, I would prefer Moderna just because there's some data to suggest that those patients mount a greater neutralizing antibody response. Having said that, whether that truly translates into lower grades of infection is still not known. Depending on whichever vaccine you have access to, but if you do have access to both, perhaps I would prefer Moderna based on data, not specifically in Waldenstrom patients, but in patients who are otherwise immunocompromised with rheumatologic diseases and solid organ transplant recipients, where a study was conducted that showed that patients who were receiving immunosuppressive agents were benefiting the most with Moderna compared to the Pfizer vaccine. Again, if you're on venetoclax, you might have to you would have to hold that as well for if you're taking simultaneously Paxlovid because of the drug-drug interaction. But outside of that, I would largely concur with what's been said, and I would definitely advocate using all measures, preventive measures, to reduce the chances, not just vaccine alone, but also masking, social distancing, and all those things. Continuing to do so, particularly if you are on immunosuppressive therapy, or are taking or have recently been exposed, even if you have stopped treatment. That's what I recommend to all my patients.
Okay. Keeping on this theme of BTK inhibitors, are there any vitamins, supplements, fish oils, etc., that should be avoided while taking a BTK inhibitor, much as there's grapefruit is ruled out for many pharmaceuticals? Thoughts on that?
Yeah, I think several oranges, star fruit, grapefruit, fish oil, drugs that could potentially enhance antiplatelet activity and increase your chances of bleeding. There are a lot of other drug-drug interactions, so let your doctor know if you're being started on a new drug and you're already taking a BTK inhibitor. And it's very easy to check if there is a potential interaction and avoid those.
I would
Dr.
consult with
Bernstein?
my
Oh, sorry.
pharmacist as well. I'm sorry. I would consult with my pharmacist as well. Oftentimes, they are excellent sources of information. Not only just the physicians, but the pharmacists sometimes can really help you answer some of these questions and notice if there
Yeah.
are any concerns, dietary concerns with certain medications or drug-drug interactions. They're part of the team.
I place a lot of confidence in our pharmacists, and with difficult questions or drugs that I'm not certain of, I will ask them. And there are programs online that you can also look for drug interactions and drug interactions. So I don't pretend to know every potential drug interaction, but I will certainly look it up or ask my pharmacist.
Several patients have to come off zanubrutinib for medical procedures. I've got one question here. The person has to go in for regular knee injections, cortisone, orthophos, several times a year. They take him off zanubrutinib. Is this detrimental to his Waldenstrom's care? Dr. Kapoor, please.
So there are certain procedures that warrant at least transient temporary holding of the drug, and if it's a major surgery, then we might have to hold for more than for close to 3, 4, and up to 7 days beyond in the peri-procedural time. But in the long run, it is not detrimental. In the short run, it might, because there is this fear or potential to get what we call the IgM rebound. If you stop BTK inhibitor abruptly, the IgM levels can go up significantly, and patients sometimes start to feel really crummy. And the vast majority of these patients, once we restart the BTK inhibitor, are able to again demonstrate a response to that approach. But there are some patients where I've also noticed where it's difficult to achieve the same degree of response that they had. So if it is just for a short period of time, typically it is okay, and in the big scheme of things, that wouldn't hurt. But you have to watch out for this IgM withdrawal as well as IgM rebound. The BTK withdrawal, I apologize, and IgM withdrawal, IgM rebound.
Oh, okay. Thank you. Night sweats. What causes them? Is there a relationship with IgM levels, and how prognostic are night sweats?
So
Well, I think.
go ahead, Dr. Burns.
No, go ahead.
No, please go ahead. That's fine.
I'm
Dr.
not sure we know.
Bernstein.
I'm not sure we know exactly what causes night sweats. I mean, that would be an interesting sort of clinical analysis to do. I mean, I do believe it's related to cytokines and different things that the disease may release into the serum. What exactly it is, I'm not sure. I mean, there are all sorts of cytokines like IL-1 and other things that can be released and can be associated with some sort of symptomatology. But I do think it can be associated with sort of more aggressive and progressive disease. I mean, most patients, I mean, my experience is compared to other lymphomas that most patients with Waldenstrom's don't have night sweats. With some lymphomas, it's much more common, but it is mediated by something that's released either by the cells or the immune response to the Waldenstrom cells as they progress. So I'm not sure it's other than the common cytokines that we always suspect. I'm not sure it's been exactly pinpointed.
Thank you very much. I think you've all seen we've got direction to wrap it up now. I want to thank all the people who submitted questions. We could not get to all of them. Many of them are of personal nature, and it's really difficult for a medical expert to give a comment without seeing the scans and the blood reports and everything else. We apologize to the patients who didn't get their question answered. It has been an absolute pleasure to have the three of you here. I think it's just wonderful. And I just thank you for your generosity with your time. I'm used to this with Dr. Berenstein. Dr. Kapoor, thank you so much. And Dr. Sherwood, I thank you for putting up with some of the difficulties technically today, and you're present as a patient and as a GP. Thank you all, gentlemen. And at this point, I have to turn this over for the closing message from the Cam Fraser, chair of the WMFC. Thanks once again, gentlemen.
Thank you.
Thank you.
I would like to thank Dr. Sherwood, Dr. Kapoor, and Dr. Berenstein for participating in our ever-popular Ask the Doctor session. With all the answers and knowledge they are providing on WM, you are giving us a much better understanding of the disease and definitely more hope for the future. Thank you for taking the time to spend with us from your busy schedules. Well, that sort of brings us to a close of the WMFC 2023 Virtual Ed Forum. We sincerely hope that you found the time that you spent with us as valuable as we did, and that you leave us here with a much better understanding of WM. I would ask that before you leave today that you complete the evaluation form that you will find at the top of the menu bar on the top of the page. Your input and suggestions are very important to us in our planning of future events just like this. On behalf of myself and all the WMFC board members, thank you for joining us at this Ed Forum. Be positive, learn from what you have heard, and be healthy. Thank you.